be talking about spatial resolution this morning. The older term for that is recorded detail. So that's more of a film term, but they really are interchangeable, talking about the same thing. We're going to look at, I'm so sorry. Brought my water bottle up here. Okay. Time change got me wanting to go to bed at 7 o'clock. There's some definitions of spatial resolution or recorded detail. There's different ones. They're all really saying the same thing. It's just a different way of saying it. So the ARRT, they have a list of definitions. So of course, ARRT is the governing body. It's the group through which you sit for the National Registry. So they say that the definition of recorded detail or spatial resolution is the sharpness of the structural edges recorded in the image. Quinn Carroll's book says it's the ability to produce sharpness in the image details. Your Faber book actually refers to it being the smallest object that can be detected in an image. And then the Carter-Veal book says the amount of detail present in the image. Detail, I don't really love. That's a little vague. So, but you can see that we're talking about how well can you see the structural lines, things like, you know, the edges of the bone, the trabecular patterns, those kind of things. How well can you see those in your image? Oh, sorry. So like I was saying, recorded detail was used more with film, the sharpness of the lines of the image. It was formerly years ago called definition. The word detail is sort of vague. So are we talking about recorded detail? Are we talking about visibility of detail? And we're going to look at what the difference is between those two things, because there is a difference. So visibility of detail is how well you can see the image. It's the overall quality of the image. It's affected by everything that went into producing the image. So the visibility of detail, in other words, in that little picture over there, you think, what in the world is that a reflection of? I have typed the word detail in that upper box, okay? But can we see it? No, so the visibility of that detail is not good, right? It's recorded there. It is literally behind that black box, but we can't see it. So the visibility of that detail is not good. The recorded detail is the same in the upper box as it is in the bottom box as far as what's recorded there, because that word detail is in both boxes. It's just that in that above one, we can't see it, okay? So we have seen these pictures before long weeks ago, and one of the first couple of PowerPoints that we went through in my class when we were just learning some of the terminology. And so in this image, the image is sharp. The things in the image, the bridge, we can even see the cars, that's sharp. But are there areas that we cannot see? Yes, so the image is sharp, but not all areas of it are visible due to the fog, okay? In this image, we can see everything in the image, but is it sharp? No, it's very blurry. It's a lot of blur. And so we can talk about that in imaging as well. So this comes from the book that we used for years when we were still doing film. It was my favorite, but it's just really out of date now. We can't really use it because it was all geared towards, it had nothing about digital imaging in it, but it was written on a very simplified level. So I loved using that textbook, but this is from that textbook. So I want us to look at this so you can understand what are we talking about when we're talking about the difference between visibility of detail and recorded detail. So it says it can be confusing at first. It's difficult to understand how a very sharp image can be produced, but we might not be able to see well. It's also difficult to understand how we can see the image well, but at the same time, it might not appear sharp, which is what we just looked at in those two images. So it says, imagine this. Think of driving to the hospital on a foggy day. You always drive past a very pretty house that sits back from the road on a rise. Only today you can't see the house because of the fog. You know the house is still there. So just because you can't see it doesn't mean that it's not there. And when the fog lifts, you will be able to see it again. On a radiograph, the image like the house can be recorded on the film, see, old term, but it may not be visible due to various conditions like too much density. Again, density was the overall blackness of the image, okay? Now imagine riding past the same house, but this time you are on your way home after an appointment with an eye doctor. The doctor puts drops in your eyes and your vision is still slightly blurred. When you look at the house, it appears blurry. You know that it really isn't blurry and that tomorrow you'll be able to see it clearly again. On a radiograph, the image may not be recorded sharply, but it is still visible. So it's just trying to help you understand the difference between those two things. So the term recorded detail, when we were using film, it's sort of like, do y'all remember those? Actually, my grandson, I bought some for him not too long ago. Those things that they were pieces of paper that had like a black covering on. And when you scratched into them, you could create pictures. You're shaking your head. You're the only one in here that know what I'm talking about.
Y'all missed out if you don't.
Yeah. So you know what I'm talking about. So you're recording that actually into that black, layer that's on top of that picture. And so with film, that's sort of like what was happening, like you were recording the image in the film emulsion. Okay, so that's why when we talk about recorded detail, it's a better term related to film. So spatial resolution is talking about the same thing, but it's just the more up-to-date term. So if I use them interchangeably, it's okay, but just remember that recorded detail is more of the older term that went along more with film. So unsharpness terms, just know, I don't know why in years ago when all of this was, just being developed and terminology and all that, why we decided to talk about unsharpness instead of sharpness. You think you'd want to be on the positive side of things and talk about the sharpness of the image. However, in radiology, we talk about the unsharpness. So I know that there's some things that are going to seem a little counterintuitive when we get to going in here, but just know that we generally will talk about the unsharpness of an image. And so the term penumbra, has anybody ever heard of that? So you're shaking your head. If you're into photography at all, you will have heard this term. So penumbra is talking about the area of unsharpness or blurry area around the lines in the image. So you can see that if the center here is supposed to be the actual object, then this lighter blue area around the object, the area of blur, would be called the penumbra, the blurriness or the unsharpness. The umbra would be the pure portion of the shadow. It's the true representation of the object. So just a few little terms there. When we're talking about resolution in general, just that broad term of resolution, we are talking about the ability of your imaging system to be able to display set structures that are actually separate as being separate and distinct. So for example, in this example, which image, A or B, has better resolution? A. Why? Who said it? I don't know where it came from. Now nobody's going to take credit for it. A is correct. Why is A correct? Come on, somebody give it a shot.
So it's showing the little line.
Yes, yes. So those holes are actually two separate holes in whatever that is. Okay. The image of it underneath there in A, they still look like two separate holes, right? In B, what do they look like? One large one, right? They're not shown as separate and distinct. So we would say that the resolution in A is better than in B. Does everybody follow what I'm saying? Okay. So when we are looking at images, we want to be able to evaluate unsharpness in the image and see if it's a level of unsharpness that we are willing to accept. Okay. So good detail, again, that's sort of vague, but I like this picture. Good detail on the left, poorer detail on the right, because there's sort of a blur there between the sharp line in that image. So here's where I was saying that things sort of seem a little odd, but it's just how you just have to learn it this way. And hopefully it'll begin to make sense as we continue to talk about it. And we'll actually, after the practical this week, we're going to do spatial resolution activities in the lab. So if unsharpness increases, so if the amount of unsharpness in an image increases, then spatial resolution is going to decrease. Doesn't that sort of make sense if you really think about it? If it's getting more unsharp, then spatial resolution is getting worse, right? If there's more blur, go back to that word, that'll try to maybe help you understand. So if there's more blur in an image, so blur is going up, then spatial resolution has to be going what? Down, right? And the opposite holds true. So if unsharpness is going down, if blur is going down, then spatial resolution is going up. If there's less blur in an image, then we can see the structural lines better, which means spatial resolution is better or increases. So this is another sentence from Quinn Carroll's book. That's, remember I told you about that thing. So even if the image is visible, it is worthless if we cannot recognize what it is. We depend upon the geometrical integrity of the image to recognize what real object it represents. So that's why we are going, so far we've been talking about visibility of detail. Now we're going to start talking about the geometric recognizability or geometric factors that go into creating our image. And those three, so you need to highlight, circle, star, underline, those three things. Those are the three geometric factors that we have to consider when we're talking about the spatial resolution of the image. So these are the geometric factors, and we're going to look at in a second, why are they called geometric factors? Well, actually, that's on this slide here. So it's because of the way the photons are affected when they pass tangentially across the edge of the object. And then they're recording information in a slightly different area. So let's look at each one of these individually and see how that affects the amount of unsharpness that's created in the image. So focal spot size and spatial resolution. So my class for the last probably 8 weeks has been all about relationships, right? If this does this, then what happens to this? We're going to continue on with that. So as focal spot size increases, so remember focal spot size, we're talking about, that wasn't supposed to pop in there yet, but that's okay. As focal spot size increases, recorded detail or spatial resolution decreases. What I wanted to say is, remember, focal spot size is related to the size of the what? In the X-ray tube? Filament. Okay. So the focal spot size is related to the size of the filament that we choose. Generally, they're dual filament tubes, meaning there's a small and a large. I was out in clinic, I think it was maybe with Delisha and Alice, and we at Patewood, and they actually had 3 selections. Was that y'all? There was 3 selections for focal spot, but only 2 of them actually worked. Okay, so sometimes you may see like 3 there, but they're not always really going to truly have more than 2. So when do we want to choose small focal spot? When we're doing what kind of exams?
Like your hands,
Yes.
smaller things.
Distal extremities, right? Fingers, hands, wrists, toes, feet, ankles. Anything that's even like a nasal bone when y'all get to that. Your nasal bone is just a very thin wafer of bone. So things that are not going to create a lot of heat, right? Because our mass values are going to be very low when we're talking about our distal extremities, because we get better spatial resolution when we have small focal spots selected. Okay. Think back to the example I gave you about painting. If I want to trim out a door or a window, I'm going to use a tiny brush, right? A small brush so I can get really good detail. If my goal is just to get paint on the wall, I'm going to use a big brush or a roller, right? Because I'm not real concerned about the details. I just want to get some paint on the wall. So think about that. So the reason this picture is here is to help you, let's see, help you realize what's happening in the X-ray tube from different areas on the filament. Okay, so what I want every one of y'all to do, and I know you're going to think that you look crazy, but I want you to hold your finger out, okay, in relation to something in front of you, preferably maybe that picture. All right, hold your finger out and close one eye and then close the other eye. What's happening to your finger in relation to the image that you're looking at? It's moving, right? Well, that's similar to what's happening at the filament. So because the filament is not one, like in other words, I just had a flash of something. In other words, if we all just had one eye in the middle of our faces, one place that we are seeing from, then we wouldn't have that issue, right? It's the same thing with the I'm so sorry. I'm just having a moment here. I'm picturing all y'all with just one having a what's that series? The old series that the Twilight Zone. With it that never mind, y'all are too young. If we had a point source, which means one spot that the photons were created off of, then we wouldn't have this issue. But it's not a point source, right? The filament is either, let's say, this long or this long. It depends on which one we choose. So the photons are being created from different points from that filament. Is everybody following what I'm saying? So that's why we're going to have a bit of unsharpness related to that, because it depends on where the photon is created off that filament and how it's striking the object. So as focal spot size gets bigger, then spatial resolution or recorded detail is going to go down. And just think of it, as your focal spot's getting bigger, there's just more what? More area length for the photons to be created from. So that's why the unsharpness is going to increase and recorded detail or spatial resolution is going to go down. Any questions about focal spot size? That's one of the geometric factors. Okay. Here's another image that you can see what I was describing. If there was just one spot that the photons were created off of, there would be no, the shadow would be pure. The umbra would be pure. It's hard probably for y'all to see. Maybe you can see. Does everybody see that there is a lighter blue around that circle? And then here, so what does that represent? That blue circle around that object. It represents what? The amount of what? Penumbra or unsharpness, right? So this amount around, I don't know why my little cursor's not wanting. This is the amount of unsharpness. So that is getting bigger or increasing as our focal spot increases in size. Because it depends on if the photon's created from this side of the filament or from this side of the filament. Again, here's just another image for you to see the difference in the amount of penumbra versus the umbra is not changing. It's the penumbra that is changing when you go from using small focal spot to large. Those are just some other images to help you visualize that concept. Now, the second geometric factor that we need to talk about is OID. So OID is the distance from the object to the IR. And we've already talked a little bit about OID as we've gone through my labs and Yolanda's lab and talking about the reason we want to try to get the part closest to the IR is to reduce the amount of OID, because as OID increases, unsharpness increases. So what kind of relationship is that? Direct or inverse? Direct, because it's saying if one goes up, the other goes up. That's direct. So as your OID increases, meaning your area between your object to your IR, the amount of unsharpness increases. So here you can see the OID is a lot less and the amount of unsharpness is less. Let's look at this picture. And you're going to actually get this from your RadTech boot camp. This is an image from RadTech boot camp. And this just says that shorter OIDs, there is less space for the photons to diverge. And longer OIDs, there's more space for the photons to diverge. So you can look at these images and see that with shorter OIDs, you're going to have better spatial resolution. With longer OIDs, you're going to have poorer spatial resolution. So that's why we want to try to always get the part as close to the IR as possible to reduce the amount of unsharpness. And then next week, we'll talk about what it does to magnification. So the third geometric factor that we need to consider is SID. So focal spot size, OID, SID. So the distance from the source of the X-rays to the IR. As SID increases, unsharpness decreases. What kind of relationship is that? Inverse. Yeah. Because what it's saying is as SID goes up, unsharpness goes down, which is a good thing, right? So again, you can see in the picture here with the shorter OIDs, just because of the geometry of the beam, because the beam diverges from the source, then the amount of unsharpness, these little areas right here, changes. And so they get much smaller the longer OID that you have. So unsharpness and distortion, we're going to just touch on briefly here because they are related as well. Both unsharpness and distortion, so both spatial resolution and distortion or magnification is basically what we're talking about. Both of those are affected by SID and OID. As magnification increases, unsharpness increases. So again, that is a direct relationship. So if you look at these images, in this image, our OID is very great, isn't it? Our object to image distance. It's greater here than it is here than it is here. So what is happening? First of all, let's talk about unsharpness. What is happening to the unsharpness in the image as the OID is getting smaller? Look at the shadow. Is unsharpness getting better, getting greater, or is it getting less as you decrease the SID? What's happening? It's getting less, right? Yes, this is less unsharpness here than here. This is very blurry. This is very blurry around the edges. Here is getting a lot crisper around the edges. So as OID decreases, unsharpness decreases. Pulling the answers out of y'all. Okay, so that's unsharpness. What about distortion, magnification? So we're going to learn that magnification and size distortion are interchangeable terms. We'll talk about that next week. But what is happening to magnification of this image as OID is going down? Is it getting more magnified or less? Less. It's getting less magnified. So that is why when we tell you we want the part as close to the IR as possible, like instead of, hovering the hand up here or putting the hand on a sponge, we don't want to do that because that makes spatial resolution go down and it makes magnification go up. And we don't want either of those things. So we can actually calculate the amount of unsharpness. Again, the unsharpness thing. I get it. It seems like we'd be positive, but we're talking about, okay, how much unsharpness is in an image? And so you're going to need to know this formula. We're going to use this formula in lab this week. So you definitely want to circle this because you're going to see this again. You're going to be asked this again. You have to understand, first of all, before you can use this formula, how you calculate the distances that we're talking about. Okay, so SID is source to image distance. And so you have source to image distance made up of the SOD plus the OID. All right, you have, let's see if I have, okay, I'll go back to the picture here in a second. This SOD is the source to object distance. The OID is the object to image distance. So if we go back to this picture up here, see how the source to object and object to image equals the source to image. Source to image distance is made up of the source to object plus the object to image, right? Everybody following?
Yes.
Okay. So you have to, when we get to this page, this is just a way to write this of how you would calculate these different distances, because you have to be able to do that to use this formula, right? So this stands for focal spot size times OID divided by SOD. That's why we have to, because it's based off of the SOD, we have to be able to calculate that. So just remember that SID is made up of SOD plus OID. Okay, it's a part of that distance. What this is saying is when we do these calculations, let's take the answer out to about 3 decimal places to make sure that we can see a difference. Because sometimes there won't be a whole lot of difference in your amount of unsharpness if you don't take it out 3 or 4 decimal places. So that's why we're going to always take it out 3 or 4 decimal places to make sure that we can see a difference, because we're going to talk about the differences in unsharpness when we're looking at different images. So for example, so we're going to learn in your lab manual, there's a couple of things that you just have to straight up memorize. And one of them is the focal spot size measurements. Okay. So the small focal spot is 0.6 millimeters. That's the physical measurement of the small focal spot. Okay. And so we're going to plug that in. We're going to plug in our 2-inch OID because our formula, again, is focal spot size times OID divided by SOD. That's the formula that we're using. Now, if I'm given the OID of 2 inches and an SID of 40 inches, how do I figure out what my SOD is? Use the formula by doing what?
Take your SID minus your OID.
Yeah, that's it. It's real easy. You just take your SID. Okay, here's your whole distance, right? Let's say that's 40. And my OID, I'm saying, is 2 inches. So I want to know what's the distance from here to wherever my object is, which is about 2 inches from the image. Okay, so subtract 2 from 40 and you get the source to object. That's all it is. So that's what we're using in the formula. So 0.6 times 2 divided by 38. And that would give us 1.2 divided by 38, or 0.0315. Now, the nice thing about this formula is we don't use any units. So like, we're not having to convert inches to millimeters or millimeters to inches. It's just sort of a arbitrary number that we can use to talk about image quality. So it's just simple. You just plug in those numbers, and then whatever you get is the amount of unsharpness in your image. So what I was saying here is, see if we had these two images done here, and the SOD for the second image is 40. Then if we did not take this first one out to 3 or 4 decimal places, see how they would both be 0.03? And we couldn't really talk about which one actually had more unsharpness or less unsharpness. So that's why I'm saying we're always going to take our answer out 3 or 4 decimal places so that we can talk about the difference. Any questions about this formula? You just have to memorize it. It's one of those things, just like inverse square law, just like, well, we haven't got there yet, but there's a couple other, just reciprocity law formula. You just have to memorize them. And we're going to get lots of practice with that today in lab, or this week in lab. So motion is detrimental to image quality. We can see that from that picture of that little dog, right? He's flying around. You can't tell anything about him because he's so blurry. So it reduces spatial resolution. It's often not perceived by the beginning student. So meaning motion can be difficult to pick up in your images because you haven't looked at that many images yet. Okay, so as you are seeing more images out there in clinic each and every week, it's going to be getting easier and easier to pick up on that. But at first it can be a little hard. Motion can be voluntary or involuntary. So motion can be voluntary, meaning that the patient can control it. Involuntary is motion that the patient can't control. So things like peristalsis. All right, can you tell your stomach, hey, be still, you know, quit what you're doing there? No, but can you hold your breath? Yes. So voluntary would be anything that you can control. Involuntary is going to be what you cannot control. Now, sometimes holding your breath could be considered involuntary, right? Okay, Maya's shaking her head. So you probably saw when you were doing portables last week, some patients that were on ventilator, possibly. So when those patients they're unconscious, they are being breathed through a ventilator. Do they have control over their breathing? No. So you would have to watch. You know, you're trying to watch when that ventilator gives them that breath and that chest rises. That's when you want to make your exposure. Hopefully, when it's at the top of that rise and prevent motion. So this is quite easy to see on this image. This motion is very obvious. Is this a child? And how do we know? Yeah, who said it? Yeah, it is a child because the growth plates have not fused yet. So here's one back here, and then here's one at the end of the tibia. That's just extra. Okay, motion on this knee. Can you see the motion on this image? Which image, left or right, has motion? Right, for sure, right? You can see all of these structural lines around the edges of the bone very nicely here. We can see all these trabecular patterns. You see those? That's what I'm talking about in the bone there. Here, actually, in here, we can see where the tib-fib joint space is. Here, we see none of that, and that's due to motion. So motion is really the biggest detriment to spatial resolution that we have. Some of these other things that affect spatial resolution we will get into next semester. So things like the thickness of the phosphor plate when we're talking about CR. Things like the pixel size and scanning frequency will determine, also be a determining factor for spatial resolution in digital imaging. But the 3 geometric factors are the ones that you have got to know. You got to understand the relationships, and hopefully after lab this week, when we do the practice problems and then we go through and we look at a chart and we say, okay, if this happens, what happens to this? And by the end of the semester, your chart's going to be comprehensive for everything that we've talked about throughout this semester. If this happens, what happens to the 4 big image qualities that we've been talking about this semester? Okay, so any questions right now related to this new material? Hopefully, again, after lab, it'll start to make more sense. Yes.
So we're doing it after this week?
Yes. Yeah, because the practical will take about probably an hour and 15 minutes, something like that. So we'll still have 2 hours at the after that to do the activities related to this. All right. So if there's no questions related to this, let's talk AEC. Because we can do a little, we've got about 30 minutes. We can do some review here for the test and for the practical, because group 1 actually has the practical today, this afternoon. So do you have specific, I know Emma, you had a specific question. What specific questions do you have related to AEC? And then I'll sort of try to summarize some things for you, but I want to address very specific questions first. I know, Emma, you want to go first? Do you want me to tell you, say what the question was? All right, so, and correct me if I'm wrong, but so her question is, how does changing the MA station, if you have the ability to, how does changing the MA station not increase or decrease receptor exposure when you're using the AEC? So that's the question. Okay, so the good thing is I noticed that St. Francis, so Maya and Cody, I didn't get to see you, but and then Mark, and who's the 4th person? Noelle, that's right. Over in the, I knew it was somebody else. So those machines actually do allow you to change the MA station when you're using the AEC if you want to. You don't have to. It comes up on a particular MA station and you don't have to change it, but you could if you wanted to. So if I did want to change the MA station for whatever reason, then if I go to a higher MA station, so I'm just remembering that the MA station came up on 320 when you were setting up for that chest X-ray, which is reasonable. 320 MA. Let's say I wanted it to have possibly a shorter exposure time on the AEC. I could increase my MA station, and that's going to make my exposure time go down because it's not going to take as long to fill the buckets up. I hope everybody did their RadTech boot camps. I haven't had a chance to look yet, but you had 2 RadTech boot camps due related to AEC. Were those not really helpful? Did you think those were helpful? So the reason that overall receptor exposure does not change is because the time is just shorter. It doesn't have to stay on as long to meet the preset charge when our MA station is higher. Because when we increase our MA station, what is that doing in the tube? It's increasing the what? Current. It's increasing the current. So when the current is going, I meant to bring a marker up here and I forgot. When the current's going up, that means more electrons are getting boiled off the filament, right? So it's going to meet that preset charge quicker. It's not going to have to stay on as long. The overall charge did not change. So the overall amount of receptor exposure did not change. Just how long it had to take to fill the bucket up. Does that make sense? Okay. What other questions? And then I'm going to get into some sort of summary stuff.
I just wanted to make sure. So basically, the automatic exposure control is to maintain.
Yeah, it's a AEC is supposed to be a way to help make the gotta wake up in here. It's too dark. It's supposed to be a way to make it easier on techs, okay? So that all you're really having to choose is your KVP, well, in your photo cell selections, and it takes the having to set a mask out of our hands. Because the AEC is ultimately in control of what?
Exposure time.
Yes, exposure time. The AEC is controlling the exposure time. It's just a way that we don't have to worry about it. Well, you know, we still have to choose the right KVP. We still have to choose the right photo cells. We still have to center appropriately. But otherwise, it's going to compensate if the patient has pathology, right? So if we don't realize that the patient has pathology and we're setting mass values, that can matter, right? The patient has emphysema and we set a mass for a normal chest, it's going to be overexposed. Whereas with the AEC, it's just going to cut off quicker. So AEC is ultimately in control of the time. Okay. All right. Any other questions related to something that you were looking at or didn't quite get before yeah.
Okay, so you just said that for the AC, we still have to select the KVP. So, for example, like last week in clinics, like it's selected. It like I don't remember putting a KVP.
No, what I mean is like that's part of the APR. When you choose chest, it's putting the KVP in there.
Gotcha.
For you. Yeah.
Okay, yeah. So the
Meaning
AEC does
that
it both.
something has to do it. Either the APR has to do it or you have to do it.
Okay.
Yeah, good question. So there's still, you know, your KVPs are going to be more sort of ranges and pretty consistent site to site. I've been out to about 4 different places this semester, and when you pull up chest X-ray, you're pretty much in the 120 range for KVP for chest at the upright bucket. What else?
So if it's, I don't remember the value, it's like 600 is your baseline. How much does increasing or decreasing the density, how much, does the question make sense? It made sense in my head.
Now 600 is your backup mass.
Oh.
600, and the other thing about you guys where y'all are is it does allow you to set a backup time. So it had a backup time, either backup time or mass, I can't remember. Along the bottom of it, it was telling us, okay, this is what your backup, and I'll come back to your question. This is what your backup time is. So if it does not have that capability, then it automatically, the backup mass is 600, which means if you do something wrong, if it will allow you, ours will not, but if it will allow you to be on the wrong method of exposure and shoot, then it's going to run till it hits 600 mass before it cuts off. That's the first part of that question.
I crossed things in my head.
Okay, what was the second part of it?
I crossed it.
Okay.
It's an unintelligible question.
Okay, well, I just want to make sure that we're covering it all. So,
because it was about density. I didn't know how much changing density.
Okay, so your density, let's talk about density setting. So if you use a plus density setting, you are actually increasing the preset charge that's required before the timer cuts off. So in the RadTech Bootcamp videos, increasing the density was equated to doing what to the bucket? Making the bucket bigger, right? Increasing density made the bucket bigger. So it's very manufacturer specific. Ours, I don't know if y'all remember, but ours goes up plus 0.5, plus 1, plus 1.5, plus 2. So ours has more increments that it uses. In general, a plus 1 would represent a 25% increase. That's never going to be a registry question because it's going to depend on the manufacturer. Okay, but just know what is true is that any plus density setting is making the bucket bigger or increasing the preset charge. Any minus density setting is doing what? Decreasing the preset charge, making the bucket smaller. So it's not going to stay on as long because the bucket's smaller. It's not going to have to stay on as long. So therefore, the mass value is going to go down when you use a minus density setting. It's going to go up when you're using a plus density setting. It has to. Does everybody understand that? It has to. If you do one image with a normal density setting, and you do another one with a plus density setting, and you change nothing else, that mass value, when you shoot it, the actual mass that pops up either on the control panel or in our case in the lab, it shows up on the image itself. It's going to go up because the time is doing what? Going up. It's staying on longer. It has to stay on longer because the bucket is bigger. Or it doesn't have to stay on as long if we're using minus because the bucket is smaller or the preset charge has been decreased. Does that make sense? So overall, the only way to intentionally change receptor exposure when you're using the AEC is to do what? Change density. So in general, if you change KVP, SID, or MA, if you have the ability to, overall receptor exposure is going to stay the same.
The only thing that changes is the time, right?
That's right.
Now, what about the like object? Like, so on the bottom, I was looking at her chart, on the bottom of the chart, the part where, yeah, with the photocells and stuff, that affects the,
That's a way to unintentionally change receptor. That's when I say intentionally, I mean on purpose. The only way to on purpose change receptor exposure is to use the density setting. We can screw up and unintentionally change receptor exposure when we didn't mean to by choosing the wrong photocell or off-centering to the photocell that we've selected. So we can either choose the outers when we're supposed to choose the middle. We can choose the middle when we were supposed to choose the outers, or we can off-center to the photocell, like the center photocell when we didn't mean to. So that will affect receptor exposure, but we didn't mean for it to. So when you're when we're doing the practical, just to review, you're going to be doing one image of everything like normal, just like we did last week in your groups. And y'all started out with the knee and you did a normal knee, everything right. Okay, that's going to be your baseline. And then you're going to be given a change. You're either going to have to increase distance, density, decrease density, increase or decrease distance. We can't do MA, increase or decrease KVP, change the photocell, go from center to outer, off center the photocell. You're going to, any of those things that we did in lab. And when we do that, you're going to talk about from the first image to the second one that you did, what changed, okay? And you're going to know if receptor exposure changed by looking at what value, the EXI. You're going to know that time changed by looking at what value, the mass. And then you're going to have to know theory to explain it. So let's take the MA example. But we can't do MA. Let's take KVP, okay? Because y'all you're not going to get an MA because we can't change it. So, for example, if your case was to go from 60 kVp to 70 kVp, all right, you're going to increase your kVp. What should happen to overall receptor exposure? It should stay the same. However, and so your EXIs should be, we'd say within 25% of each other. They should be way closer than that. But you know how we just say, okay, as long as the second one's within 25% of the first one, we're good. We maintain. So receptor exposure should stay the same, and we're going to look at our EXI values. What's going to happen to our exposure time when we go from 60 kVp to 70 kVp? Is it gonna go up? And Avery's going, it's gonna go down. He's right. Exposure time is gonna go down, right? And we can prove that by looking at the mass values, right? After we shoot it, we're gonna get a mass value. So we can use our EXIs to talk about receptor exposure being maintained. We can talk about our mass values to talk about whether or not our time went up or down. And the reason, the theory is when you increase KVP, what two things are happening? We've talked about this over and over. When we increase KVP, what two things are happening in the tube and to the photons? More photons are being created to begin with. And those photons have what? Higher energy. Therefore, the bucket is going to fill up faster, so it doesn't have to stay on as long. That's the theory. That's the why. So if you want to get all of the points, you have to use your, you have to use your EXIs, your mass values, and you have to be able to write a sentence about what is happening. So you're going to specifically say, my EXI was 250. On my second image, it was 265. Therefore, my receptor exposure stayed the same. My mass value was, I'm totally making these up. My mass value was 4 on the first one. My mass value was 2 on the second one. I know my time went down because my mass went from 4 to 2. Yes.
Can we use like the term like bucket? Like I know that's not, you know.
I would rather you not use the bucket to understand preset charge is the key term.
Preset charge.
Relate the bucket to preset charge. The size of the bucket is related to the preset charge, the amount of charge that's required to send the signal to the timer circuit to cut off. Let's talk backup mass a second. So if your equipment gives you the ability to set a backup mass, and let's say, I'm just doing this totally hypothetical, let's say your expected mass on an abdomen was 100, right? 100 mass. What would you want to set your backup mass to? 200, please. You could say 150 to 200 because it's 1.5 to 2 times what your expected mass is. And that's just, when you have the ability to set a backup mass, that just prevents some overexposures if you make a mistake. That's what backup mass is all about. It's about safety. Patient and equipment, really, safety. Because you don't want to be running that equipment up to 600 mass over and over and over. So backup mass is related to keeping the patient safe and the equipment. It's 1.5 to 2 times what your expected is. If you come up with a backup mass, then you could figure out what a backup time would be if I give you an MA station by using what formula?
No.
Reciprocity. Think about what I'm giving you. If I'm giving you a mass and I'm giving you an MA station, what is the only thing left to find? Time. So you should still be able to do, you have to be able to use reciprocity formula for the rest of your life. Depends on how, if you, hey, let me just say, let me stop this recording.